agents. And this is the initiative of West Bengal Academy of Pediatrics. And we are humble and honored to get Professor Surjit Singh as he will be delivering this lecture in this second session. We have with us Dr. Neelam Mohan, the President-elect of 2025. So I'll request Dr. Neelam Mohan to deliver a few words. Over to you, Dr. Mohan.
Thank you so much, Dr. Swapan Ray, and it's indeed a pleasure to be here today when the amount of academics that is being done. West Bengal is totally geared up to host the Pedicon. And with that, they are also doing so much of academic work, which they would always do. But probably now they are putting themselves in the fourth and the fifth gear. And the team that is involved with them is totally uh, applaudable and praiseworthy. It is not only one, they are one representation who talk about the entire team, whether it is Swapan, whether it is Priyankal Pal, Kripa Sindhu, Ashok Datta, Mihir, Dibyendu, Kalpana Ma'am, Kanta Chatterjee, Amita, or Indu Surana. Everybody work unanimously to ensure that the activities are of the highest academic quality. And of course, Atanu belongs to West Bengal, but he is representing us from the Central IAP too. It is such a delight to have Dr. Surjit Singh, and he requires no introduction, but he's someone who is been doing us so much proud, and he is popular across the globe when it comes about talking and his work that he's been contributing. We have seen that they are a center even of excellence for WHO collaborating center for these, and the amount of work during the time of COVID, that was there was confusion about Kawasaki and all, and I remember there were many who wanted to listen to Dr. Surjit Singh. And just being a hepatologist, a couple of words I would like to say. Though we all know that this is, something more vascular and immunological, but it is extremely important for pediatricians to realize that you can see this disease from various angles. Not only the angles which the common presentation goes, but I was fortunate enough to diagnose quite complicated cases who had actually come to me with some deranged liver test, and the eyes sees what the mind knows, and we were able to detect it. And to the tune of 40%, you may have abnormal liver enzymes in this. And of course, occasionally liver failure and deranged liver tests are also known. So without taking much time, I am all anxious to listen to the legend with 3 decades of experience, Dr. Surjit Singh. Absolutely excited to have you over on this platform and hearing you. Thank you once again for giving this opportunity to me to welcome such a stalwart. Thank you.
Thank you, Dr. Neelam Mohan. Now I'll request Dr. Atanu Bhadra, the National Treasurer, to say a few words.
So when the president-elect says, I think there is nothing remains to add to it, but we'll welcome Dr. Surjit Singh, sir. We had him presenting many lectures in West Bengal, and he is a regular to Calcutta and even Howrah also. Sir, we not only appreciate your stature that you have placed Indian academics, IAP academics to the high stature that you have placed it, but also we like him for many other reasons, particularly the story about Jallianwala Bagh. So, sir, we really were honored to have you on this legend. And Shapun, please continue.
Thank you, Atanu.
I would request all the audience, please, to all the audience are welcome to the Pedicon 2026 to be held by all these stalwarts that you can see on this podium, the organizing team. They are all there to welcome, and I join hand in hand with them, and we promise a stupendous performance in academics. Thank you.
Thank you. So now I'll request Professor Dr. Priyankar Pal, the HOD of Institute of Child Health, who also have the highest registry of the Kawasaki disease in Eastern India. So over to you, Professor Pal. Please introduce Professor Surjit Singh, sir. Actually, Professor Surjit Singh, sir, needs no introduction. Still, as a customary, you have to do this duty. Over to you.
So I think, as already said many a times, Professor Surjit Singh in an academic forum needs no introduction. He is the guru. He is the guru of pediatric rheumatology in India. And definitely, he's the one who has been instrumental for years together in spreading awareness of Kawasaki disease. So I think from his first publications in 1997 on Kawasaki disease in Chandigarh, and then he was also instrumental in bringing Dr. Kawasaki to Chandigarh in the Pediatric Rheumatology Conference made in 2005. And possibly, as I say, that was a watershed zone. That was a watershed year when Kawasaki awareness actually went leaps and bounds. So, sir, he is the head of the department of pediatrics and the chief of pediatric allergy and immunology at the Advanced Pediatric Center, PGIMER, Chandigarh. So I don't think I would go on telling anything more about sir. It's rather we listen to him speak on the disease, the enigmatic disease that is Kawasaki disease. Over to you, sir.
Should I start, Dr. Swapan?
Yes, sir.
Okay. Okay. Good evening. So I thank the West Bengal Academy of Pediatrics for giving me this opportunity to talk about Kawasaki disease. This is a disease in which Calcutta itself has played a major role, a very major role in recognizing this entity in Eastern India and in spreading awareness about this entity across the country. So there are many things that we can discuss about Kawasaki disease, but I thought the best way to talk about this condition would be to recount our experience over the last 3 decades and also to highlight some of the mistakes that we have committed and the lessons that we have learned from these mistakes over the last 30 years. So we diagnosed our first patient of Kawasaki disease in 1994. We published that case as a case report in 1996. The first small series on Kawasaki disease from our institute was published in 97. So it's been exactly 30 years since we first diagnosed our patient with Kawasaki disease. The story dates back to 1990 when I went on a fellowship to the Hospital for Sick Children, Great Ormond Street, London. And it was here that I saw my first few cases of Kawasaki disease under Professor Roland Levinsky and Dr. Mike Levine. Dr. Mike Levine still continues his interest in Kawasaki disease and is a regular participant at the International Kawasaki Disease Symposia, which are held every 3 years. It was under them that I first saw children with Kawasaki disease. As I was leaving after my fellowship, I remember Dr. Levinsky asking me, "Will you ever get to diagnose these patients in India?" So I said, "Sir, I don't know because I haven't seen these patients ever in India." But I'm sure that was not a correct statement. We must have seen these patients, but we never diagnosed them. We must have misdiagnosed them as viral exanthemata or whatever. So that is how the story began. Kawasaki disease is a medium vessel vasculitis with a special predilection for the coronary arteries. It usually affects children below 5 years. However, older children and adolescents can also be affected. Diagnosis rests on recognition of a characteristic constellation of clinical findings. And as pediatrician, we have to be familiar with this constellation of clinical findings because there is no pathognomonic laboratory test for Kawasaki disease. It is entirely a clinical diagnosis, and you have to be on the lookout for KD in any child whose fever has not settled down in the first 3 to 5 days, and especially in children in the preschool age group. That means less than 5. So if you have a low threshold for picking up KD, it's quite surprising the number of patients that we can pick up while managing children in the outpatient clinic or in the emergency room. The diagnostic criteria are very straightforward. They have been modified every few years, but essentially they are not very different from what Dr. Kawasaki himself gave in the year 1967. And the broad principles are fever for at least 5 days, presence of 4 of the following 5 conditions: conjunctival injection, cervical adenopathy, rash, mucosal changes, and acral skin changes, and illness not explained by other known diseases. So these are the broad guidelines. These are essentially guidelines to the diagnosis because a substantial number of these patients will turn out to have incomplete Kawasaki disease. So once you have diagnosed your first 30-40 patients of Kawasaki disease, one becomes more confident in picking up the diagnosis in even patients who do not have the complete spectrum of Kawasaki disease. Typical cases of Kawasaki disease, generally speaking, are not missed in our country in most metropolitan areas. So big cities, big towns, the awareness about Kawasaki disease is now much, much better than what it was 3 decades ago. And due credit for this must go to the Indian Academy of Pediatrics, because for the last 25 years or more, they have always been very gracious in giving us time to talk about Kawasaki disease. And quite often there is discussion on Kawasaki disease under the rheumatology chapter of Indian Academy of Pediatrics, under the infectious diseases chapter, under the pediatric cardiology chapter. The result is that these days, typical children with Kawasaki disease are unlikely to be missed, and it is only the more difficult patients or the more atypical patients that would get missed. The first lesson that we learned was that Kawasaki disease is a common condition. In fact, it is the commonest vasculitis in children, and Kawasaki disease as a vasculitic disorder is more common than all the other vasculitic conditions combined together. It is far, far more common. At Chandigarh, we pick up prior to the pandemic, we were picking up somewhere between 130 to 150 patients every year. That is how common this condition is. In big cities like Delhi, Calcutta, Mumbai, this figure would be in thousands of cases. The lesson 2 that we learned was that not only is it the commonest vasculitis in children, it is a very common condition in young children. So this is from a review article that we wrote in 2019. There are 3 categories of countries. Category 1 are countries like Japan, Korea, and Taiwan, where the incidence rates of Kawasaki disease are upwards of 80 per 100,000 children less than 5. In these 3 countries, we have very accurate nationwide data. And the incidence of KD is continuing to rise in all these countries. Category 2 is the the developed part of the world, Europe, North America, Australia, New Zealand, the incidence rates of KD are in the range of 15 to 30 per 100,000 children. But incidence of KD in these regions has plateaued. It is not increasing, unlike category 1 countries. And category 3 are the big countries like India and China, where we do not have nationwide data, but we do have city-specific incidence rates. So China, the incidence rates vary from 7.1 to as high as 74 in Hong Kong. In Chandigarh, our latest incidence figure is 10.6. So that means the incidence in Chandigarh is at least as high as that in some of the European countries. So again, the global epidemiology of KD suggests that the 3 countries that have the highest incidence, that means Japan, Korea, and Taiwan, the incidence continues to increase, and that is a source of great worry for these 3 countries. All other countries have incidence rates that are much lower than these 3 countries. In Chandigarh, we have been maintaining a hospital-based registry since 1994, and it is since that time that we have been trying to estimate, I won't say calculate, but estimate incidence figures for Kawasaki disease based on our hospital data. And the incidence rates have continued to increase over the last 30 years. And the latest incidence that we have is 10.6 per 100,000 children less than 5. That is a 2019 data, which is just prior to the pandemic. So in other words, over the last 25 years, incidence rates of KD at Chandigarh have risen 7 times. And we have peaks in April, May, and in October, and the nadir of Kawasaki disease in Chandigarh falls in February. We have also been able to calculate the linear trend of Kawasaki disease at Chandigarh with the help of our Department of Community Medicine, and this shows that the linear trend of KD continues to increase. So KD is a common condition in children, and the incidence figures at Chandigarh in 2019 were 10.6 per 100,000 children below 5. During the pandemic, the incidence of KD came down, just as it came down in most countries across the globe. Lesson 3 that we learned was that KD and not acute rheumatic fever is now the commonest cause of acquired heart disease in children. So this is from a review article written by Dr. Krishna Kumar and Dr. Raj Tandon in the Indian Journal of Medical Research, which shows that the incidence of rheumatic fever has come down gradually and will continue to go down if you go up till 2026, while the incidence of KD continues to increase. So in Chandigarh, the incidence of KD is at least 50 times that of acute rheumatic fever, and pediatricians across India have been seeing similar trends. This again is a linear trend analysis for Kawasaki disease and acute rheumatic fever at Chandigarh, which shows that the incidence of KD will continue to increase till at least 2030, while the incidence of rheumatic fever continues to decrease. And this is the prediction analysis going up till 2030, which shows the same trend. So this is from an article that we have just published in the journal Cardiology in the Young, highlighting the fact that KD is now the most common cause of acquired disease among children, not only in the developed world, but also in the developing world. So globally now, Kawasaki disease has become the most common cause of acquired heart disease in children. Lesson 4 that we learned was that more than half the patients of Kawasaki disease that we see at Chandigarh do not meet the diagnostic criteria. And this is what we call incomplete KD. And it is this category of patients that can be very difficult to diagnose sometimes, especially when KD presents in infants, and especially in infants below the age of 6 months. Some patients with KD have unusual clinical presentations. That means that they may have systemic presentations. This could be hepatic, renal, neurological, and this is what is called as atypical KD. So these presentations of KD can sometimes be exceedingly difficult to diagnose, but diagnose we must, because these presentations can have severe sequelae, severe coronary artery sequelae. So some children with KD, for instance, can have predominant presentation of arthritis, and one can miss the main diagnosis of KD. Systemic involvement, they can present with involvement of the lungs, liver, kidneys. These are all unusual presentations of KD, and unless you have a very low threshold for considering this condition, one can go at a tangent and miss the diagnosis. Some children with KD, like all rheumatological disorders, can present with macrophage activation syndrome. And this again can be exceedingly difficult. When a child with KD presents with macrophage activation syndrome, this can test the clinical acumen of almost everyone. So KD is a vasculitis, and there are many vasculitic disorders and many rheumatological disorders that can present with macrophage activation syndrome, and KD is no exception. So macrophage activation syndrome may be seen in 1 to 2% of children with KD, and these children may present with fever, rapidly progressing thrombocytopenia, bleeding disorders, and unless you are on the lookout for KD, you can miss the diagnosis, and this can result in fatalities. Lesson 5 that we learned was that KD remains a completely clinical diagnosis. There are no well-known biomarkers for Kawasaki disease. The only biomarker that we have found useful is the pro-brain natriuretic peptide, that is pro-BNP. And at our center, if the pro-BNP levels were above a cutoff of 1025 picograms per ml, this had an 88% sensitivity and 96% specificity for diagnosis of KD. Other than pro-BNP, there is hardly any other marker that can be useful for diagnosing Kawasaki disease. Lesson 6 that we learned was that although Kawasaki disease is usually a disease of preschool children, that means children below the age of 5, it can also occur at extremes of age. That means it can occur in infants, very young infants sometimes, and it can occur in adolescents and occasionally even in adults. And it is at these extremes of age that not only is the diagnosis very, very difficult, but you can be faced with several therapeutic conundrums. So why is the diagnosis difficult when KD presents in infants? The reason is that whenever KD presents in infants, it is almost always incomplete. That means that the full criteria may not often be met. So this was a 4-month-old girl who had fever for 12 days, extreme irritability, had diarrhea, but she had perineal rash and BCG reactivation. So based on these clinical findings, there is really no differential diagnosis. But if you start applying the KD criteria, you will miss the diagnosis. And this child had a very severe form of KD, and she went on to develop giant aneurysms. Kawasaki disease below the age of 6 months can be one of the most difficult conditions to diagnose in clinical pediatrics. So it is just like diagnosing systemic onset juvenile arthritis in infants. It is very important to pick up these children because not only is the diagnosis difficult, but these children usually have a very high risk of coronary artery involvement. So when you pick up KD in infants, and especially in infants below 6 months, almost always we would use several other medications in addition to intravenous immunoglobulin. In these patients, we would give what is called as preemptive adjunctive therapy. That means we would give them infliximab, steroids, intravenous immunoglobulin, and more often than not, even cyclosporin. So Kawasaki disease in infants is not only difficult to diagnose, but you have to be very aggressive with the therapy. Occasionally, Kawasaki disease will present in children above the age of 10, in adolescents or in young adults. And here again, the diagnosis can be very difficult because many of these patients would report to adult physicians, and adult physicians may not be adequately equipped to diagnose and to treat Kawasaki disease. So the diagnosis is often delayed when Kawasaki disease occurs in adolescents or young adults. This was our oldest patient of Kawasaki disease. This was a 27 years old lady. She was a medical doctor, a doctor herself. She presented with fever, rashes, cervical adenopathy, and she received several courses of antibiotics for these findings. It was only when she had desquamation that she went to a dermatologist, and the dermatologist diagnosed this as Kawasaki disease. She had been having red lips and tongue from the beginning, but this was missed. So the dermatologist referred this child to our unit, and I mean, this was one of the few occasions when we had to admit an adult in the pediatrics ward. She went on to develop aneurysms in the coronary arteries, but fortunately, she responded to intravenous immunoglobulin therapy, and the aneurysms gradually regressed. So Kawasaki disease is not only a disease of young children, it can occur in extremes of age. So the lesson is that whenever you have a febrile patient and the fever has not settled down over 3 to 5 days, be on the lookout of Kawasaki disease, because unless you suspect it, you will miss the diagnosis. The seventh lesson that we learnt was that Kawasaki disease is much more than just coronary arthritis. Although when you talk of Kawasaki disease, we usually have in our mind coronary artery dilatation, ectasia, aneurysms. But Kawasaki disease has myocardial dysfunction as an integral part of the disease. Myocarditis is almost universal in Kawasaki disease. Similarly, Kawasaki disease can have significant valvular regurgitation. You can have pericardial involvement. You can have aortic root abnormalities. So it is more like a pancarditis. The myocarditis of Kawasaki disease was first highlighted by Dr. Najib Dada from Montreal in Canada, and it was he who wrote this article in 2010 and gave a very catchy title, "Not just coronary arthritis, Kawasaki disease is a myocarditis too." So Dr. Priyankar was here with us in 2018 when Dr. Najib Dada had come to Chandigarh, and he had shared his experience of KD myocarditis. So this myocarditis can sometimes be so severe to present as KD shock syndrome. So the myocarditis in KD and the coronary artery involvement in KD are two different things. And children can have either of the two or both of the two. So Dr. Najib Dada highlighted the fact that while coronary artery abnormalities develop in only 15 to 20% patients with KD, myocarditis is almost universal. In most of the patients, this myocarditis is clinically silent. It's not symptomatic. But when it is symptomatic, it can present as congestive cardiac failure. And in some patients, myocarditis can be the most important clinical feature of KD. And children with KD can sometimes be lurking around in the intensive care unit. And when a child in the ICU presents with fever and shock, these children are very likely to be misdiagnosed as septic shock syndrome. So the lesson that we learned was that if there is a febrile child with shock in the ICU and the blood cultures are repeatedly coming as sterile, think of KD shock syndrome, because these children can have very subtle findings of Kawasaki disease that can be easily missed unless you are looking for these findings. So this was one of our first few children with KD shock syndrome, and this is about the most severe form of KD that we have ever got to see at Chandigarh. This child presented with macrophage activation syndrome, severe myocarditis. He required as many as 3 doses of IVIG, required infliximab, required steroids, required cyclosporin. He needed ventilation. He needed several inotropes to come out of the shock. And it was after several days that this child recovered, but recovered completely. He is completely normal on follow-up. So this was how we learnt about Kawasaki disease shock syndrome. So we now talk of the expanded spectrum of KD. We must realize that KD is a vasculitis, and like all other vasculitides, it can have very many different presentations. So it can involve several systems, and depending on which system it has affected, these children can have varying clinical presentation. So you have KD in infants, you have children with gangrene, you have children who have neurological involvement, renal involvement, eye involvement, GI involvement, pulmonary involvement. You can have children that have predominant macrophage activation syndrome. You can have children that can have predominant myocarditis and KD shock syndrome. So there is a vast spectrum of Kawasaki disease that we as pediatricians need to be aware of. The 8th lesson that we learned was, again, a very important lesson, and that is regarding echocardiography. We at Chandigarh believe that echocardiography has been given far more importance in KD than it actually deserves. There are several problems associated with echocardiography, and these are usually not highlighted. First, the reports of echocardiography depend on the expertise of the echocardiographer. Now, in most centers in our country, there would not be a pediatric cardiologist who would be readily available to report on children with KD. And this is because there is a dearth of trained pediatric cardiologists in our country. So at many centers, echocardiography reports are given by adult cardiologists who may have either little or no training, virtually no training on reporting on children with KD. And I think it is too much to expect an adult cardiologist to have the patience and the time to do the echo on a struggling infant who is crying, who is irritable. So the reports that you get from such examinations would be very equivocal. There can be significant inter-observer variability. The Z scores that are given can have several inbuilt fallacies. The red scores will be very inaccurate if the weight of the baby has not been calculated, has not been measured correctly, or if the length or height of the baby has not been measured accurately. And these measures are often not given the importance that they deserve. In India, the other problem that we have faced is that if a pediatrician diagnoses a child as Kawasaki disease and you refer him to a cardiologist, he may do a very cursory examination and tell the parents that this child has a normal echo, he does not have KD. And the moment a cardiologist says this child does not have KD, the parents are more likely to believe the cardiologist than the pediatrician. And we have faced this in Chandigarh, and this is a very, very common problem that many pediatricians would face. We must remember that for the diagnosis of KD, echocardiography is not required. KD is a clinical diagnosis. You do not need a cardiologist to diagnose children with KD, just as you do not need a cardiologist to diagnose children with acute rheumatic fever. When you do echocardiography, you have to repeat the examination at frequent intervals. In our unit now, we have an echocardiography machine right in the ward, and we would do the echo on a daily basis. This echo is done by our DM fellows who are doing their DM in pediatric rheumatology. They do the echo and they do it on a daily basis. We must also remember that a negative echo does not rule out KD. Echo has to be negative in the first 7 days, and we have to diagnose KD in the first 7 days. The coronary artery changes do not manifest in the first 7 days. So these are the various problems that we have encountered with echocardiography, and it is as a result of these difficulties that we acquired an echocardiography machine of our own, placed it in the ward, and started doing it ourselves. That means by our DM fellows, who after a few months are reasonably adept, reasonably proficient in doing a good job of measuring the coronary arteries. We have also learned that echo is not enough for diagnosing the coronary involvement in Kawasaki disease. And here comes the role of CT coronary angiography, which has been pioneered at our center by one of our cardiac radiologists, Dr. Manfool Singh, who has been working on this aspect for the last now 11 years. And he has developed a paradigm for CT coronary angiography in Kawasaki disease, by which he can do the procedure at a radiation exposure less than 1 millisievert. This is about the lowest radiation exposure ever reported anywhere in the world. So he started doing this procedure on a 128 slice dual source platform. We now have a 386 slice dual source platform, and our present day radiation exposures are less than even 0.5 millisieverts. It was ever since we started doing coronary angiography that we realized that the damage caused by Kawasaki disease is far, far more extensive than what appears on on echocardiography. Echocardiography does not pick up changes in the distal coronary arteries. Echocardiography does not pick up changes in the left circumflex artery. Echocardiography may miss coronary calcifications. And for these findings, there is you have to do the CT coronary angiography, but the trick is that you have to learn to do it at low radiation exposure. If you get this procedure done by a routine as a routine procedure by any radiologist, the radiation that can be given to these babies can be as high as 10 to 15 millisieverts, which is totally unacceptable. So we have to learn to do the CT angiography. For this, you need a dual source platform, you need a trained radiologist, and you have to use special parameters and special software to decrease the radiation exposure. So this is Dr. Manful's publication on distal coronary artery abnormalities in Kawasaki disease, and he showed that distal coronaries can also be involved in children with Kawasaki disease in addition to proximal coronary arteries. Here, Dr. Manful has shown that the left circumflex coronary artery is also quite frequently involved in children with KD, and this is entirely missed if you restrict yourself only to echocardiography. So this is a study in which we followed up these children after a few years of Kawasaki disease, and these children had had spontaneous defervescence, and we thought their echoes were normal. It may be worthwhile doing CT coronary angiography to really prove that there was no residual coronary artery disease. The ninth lesson that we learned pertains to treatment. We know that intravenous immunoglobulin is the therapy of choice, and it has remained the therapy of choice over the last 30 years. So when you have a child with Kawasaki disease, there is no choice but to give intravenous immunoglobulin and start the treatment as soon as possible. But what we have also learned is that a substantial number of children with KD require adjunctive therapies. And who are these children? KD in infants would almost always require adjunctive therapy. Patients with severe forms of KD, for instance, KD shock syndrome or macrophage activation syndrome, would require adjunctive therapy. Patients who have coronary abnormalities right at presentation, they would require adjunctive therapy. And patients who have KD myocarditis or IVIG resistance, they would require adjunctive therapy. So in many of these patients, we would give preemptive adjunctive therapy. That means you have KD in a young infant, we would immediately start infliximab, first infliximab, then we would give IVIG, we would give steroids, and we would also give cyclosporin. You have a child with KD myocarditis, we would give IVIG and start steroids immediately. The options for adjunctive therapy are many. At our center, we prefer using infliximab as the first option, but you can also use a repeat dose of IVIG, steroids, cyclosporin, anakinra. So these are several forms of therapy that can be used as adjunctive therapies in children with KD, and more than half the patients with KD at present, we would use drugs other than IVIG for treatment of Kawasaki disease. So we have learned that KD is not the same in all children. So you have to identify children who require more aggressive forms of therapy and use those therapies so as to decrease their chances of cardiac involvement. So infliximab we started using in 2007. Soon after, Dr. Jane Burns had visited our unit in 2006, and it is since that time that we have been using infliximab. And this was one of our publications around 2011 or 2012, in which we had given our experience of 23 children, the first 23 children with infliximab. And we realized that it is a useful adjunct in treatment of children with KD. We have also realized that a child with severe KD, infliximab works like magic. It is a very good hit drug for severe forms of KD. The last lesson that I would like to talk about is that KD is not a one-time disease of childhood. It can leave behind several sequelae. So when you see a child with KD, the parents often ask that after the child has been treated, that my child will be normal. It is very natural for the parents to ask that. But I am afraid children with KD may not always become normal, even if the coronary arteries have regressed. Because once a coronary artery is involved in Kawasaki disease, it perhaps never becomes normal. It may look anatomically normal, but functionally these arteries are not normal. Kawasaki disease also involves the other arterial systems in the body. And these are studies that we have done over the last 25 years, in which, for instance, we have measured the carotid intima media thickness in children with KD. We have measured the same after a follow-up of 6.9 years, and we have found that these changes persist. We have done endothelial function studies in children with KD. These are all small studies, but they have highlighted the fact that KD can impact several systems, several arterial systems in the body. Calcification of the coronary arteries is a major complication of KD. And early forms of calcification can be entirely missed on echocardiography. It is important to pick up calcifications because children who develop calcifications of the coronary arteries, when they grow up to be adults, they would not be suitable candidates for either angioplasties or coronary artery bypass grafts should these children ever require these forms of therapy. And these calcifications can appear sometimes within a few months of the episode of acute Kawasaki disease. In others, it may take a couple of years for the calcifications to appear. And it is only after we have started doing coronary angiography that we have realized how dense these calcifications can be. For instance, in this child had Kawasaki disease when she was 3 years old. And after a follow-up period of 8 years, when we did the CT coronary angiography, she had dense calcifications, and her calcium score for this calcification was that of a 70-year-old patient. That means the calcifications that you would normally see in a 70-year-old patient with atherosclerosis, we got these calcifications in a girl who is only 11 years old. Kawasaki disease, when it occurs in children and the diagnosis is missed, these patients are not treated, the coronary damage that occurs and the coronary stenosis that can appear can present as myocardial ischemia in young adults. So it is said that if you have a young adult admitted in the coronary care unit who has no risk factors for coronary artery disease, no family history of coronary artery disease, one must think of Kawasaki disease in childhood. So in this publication, we reported on 4 patients with ischemic heart disease who had presented to the adult cardiologist with no risk factors for ischemic heart disease, no family history, and their angiographies had shown these aneurysms. These are not atherosclerotic aneurysms because atherosclerotic aneurysms would not be localized, they are generalized. So whenever you have coronary aneurysms that are localized to particular segments of the coronary arteries with normal coronaries elsewhere, these are very suggestive of Kawasaki disease. So KD in childhood can have sequelae that last an entire lifetime. So it is so very important to diagnose Kawasaki disease and to treat children with Kawasaki disease appropriately. So I come to the end of my talk and I pay my tributes to the legend, Dr. Tomisaku Kawasaki, who was born on 7th February 1925 and who passed away on 5th June 2020 at the age of 95. And this is the legacy that he left for all of us to work on. Dr. Kawasaki disease, those of us who have had the honor and the privilege of having met him, was a quintessential pediatrician. He simply loved children. And he was very fond of saying that you have to be strict while studying medicine, but be warm-hearted while caring for patients. And the sight of children used to excite him and bring a smile on his face, just the sight of children. This is one of the last few photographs of Dr. Tomisaku Kawasaki, and this was taken a few weeks before his demise when he was admitted in a nursing home in Tokyo. And by his side is Dr. Hirohisa Kato, which Dr. Priyankar would recall. Dr. Kato had accompanied Dr. Kawasaki when both of them had come to Chandigarh in 2005. So Dr. Kato was a lifelong colleague of Dr. Kawasaki, and he was the man who had done the first few digital subtraction angiographies in children with KD. And he had done these procedures in the 70s when the equipment was very primitive. So he was the first person to document coronary aneurysms in children with KD during life, much before echocardiography became available. These are the two daughters of Dr. Tomisaku Kawasaki, and Subura, the younger daughter, has been to India, and she had come at the last Indian Society of Kawasaki meeting that we held in Patna, and before that she had come when we had held this meeting in Chandigarh, and this is the son of Dr. Tomisaku Kawasaki. So this is about the last few photographs that the family has of Dr. Tomisaku Kawasaki. And remember that even in those difficult times, the smile never escaped Dr. Kawasaki. This is the resting place of Dr. Tomisaku Kawasaki. And this is not very far from the Japanese Red Cross Hospital, the hospital where he first discovered this condition and the hospital where he worked his entire life and from where he retired in Tokyo, the Tokyo Red Cross Hospital. So his final resting place is very near that hospital. And this is Subura Kawasaki and his son placing flowers at his grave. And Dr. Tomisaku Kawasaki and his wife, Dr. Riko Kawasaki, these are their stones next to each other at that resting place. This is a review article, an editorial that we wrote just a few weeks ago on the occasion of the 100th birth anniversary of Dr. Tomisaku Kawasaki, which fell on February 7, 2025. So this was the 100th birth anniversary of Dr. Tomisaku Kawasaki. And these are, of course, pictures of Dr. Kawasaki when he had come to Chandigarh in 2005. And here he is talking to parents of children with Kawasaki disease. Thank you very much. So this is my last slide.
Thank you, sir, for your mesmerizing talk. We are just glued to it. So if you permit, some questions are there, sir. Can I put them?
Yeah, definitely.
So it's by Dr. Mihir Sarkar, our Secretary of West Bengal Academy of Pediatrics. He said,
Should I stop sharing the? Should I stop sharing the?
Yeah,
screen?
you can, please. So
Yeah.
he has asked, we have seen sick febrile patient in ICU with sepsis and other infection like strab or dengue having multi-organ dysfunction along with coronary artery dilatation. Even Z-score is more than 2.5. Where to fit this group of children in the diagnosis? Some scrub typhus and dengue patient presenting with multi-organ dysfunction have coronary artery dilatation with a Z-score of more than 2.5. So where to fit this group of children in the diagnosis?
It's a difficult question, but if the diagnosis of scrub typhus is clear or dengue is clear, obvious, and supported by the lab, one would focus on treating the primary condition and observe the coronary changes. This is usually not Kawasaki disease, even if that Z score is high, because Z scores can sometimes be high in several febrile conditions, but that does not make it Kawasaki disease. So with Z scores, again, I would say that our experience with Z scores has been, quite equivocal, because a lot depends on who is measuring the Z scores, whether the length of the child, the height of the child, the weight has been taken accurately, and which Z scores you are using. We do not have nomograms for India. With the same coronary measurement, if you use different Z score, different scores, you will get different figures, values for the Z scores. For instance, you have the Delaire Z scores, you have the Boston Z scores, you have the Japanese Z scores. So Z scores are, a very, very controversial entity. So one has to use one's clinical judgment while managing these patients and, take it day by day.
Sir,
Can
another
I give a
question.
comment on that, please?
Please, Leela, please.
Yeah. So I just wanted to mention, since that question I've been of scrub typhus, I remember having a patient exactly like that. And the patient was fortunately admitted under me and had obvious some liver function designs. And the ICU team, as they thought that there's a borderline that you should start with IVIG. And smartly, in the same scenario, I did a scrub typhus PCR. And like you can have an antibody which is false positive, but you can't have a PCR. So that child PCR was positive, and I sat on the child. I said, I don't think this child has other thing. And then the child is on follow-up with more than uh, 1.5 years or so. The child was from Banaras. And so, as he rightly said, sometimes we have to look into that borderline. And when you have a team and everybody wants to say, so doing a PCR was very useful to me. And we did get the report within a day of PCR.
Thank you, madam, for your insight. Next question is, thrombocytosis is not a pointer to diagnosis of Kawasaki disease. Sir.
Thrombocytosis does not appear in the first 7 to 10 days. It appears after the first week. We have to diagnose KD in the first 5 to 7 days. So we do not wait for thrombocytosis. Thrombocytosis is supportive of the diagnosis of KD, but by the time thrombocytosis appears, it may be too late. The coronary changes may have already appeared.
We have published one paper by Dr. Raju Thapar, and Priyankar was also probably there. Thrombocytopenia in a young child, a young infant presenting with Kawasaki. They're presenting with Kawasaki. Priyankar, your comment? The thrombocytopenia Raju Thapar has presented.
That was the neonate. That was,
Neonate.
as far as I
Neonate
remember,
with-
it was a 21 day or 23-day-old neonate.
Yeah.
And that baby had a thrombocytopenia. And if you look at Kawasaki literature, So thrombocytopenia is a bad prognostic marker. So that baby also had aneurysms. So it was a neonatal
Yes.
KD, which also had aneurysms.
Okay. So another question, why rheumatic fever decreasing? Better living conditions?
Probably. It's a sign of economic development in our country, and our standard of living has definitely gone up, and probably easier access to antimicrobials as far as children with sore throat are concerned. But no one really has the complete answer.
Somebody has put the questions that why the incidence of KD decreased during COVID time.
I mean, if Kawasaki disease is caused by an infectious agent, so during COVID times, the isolation that was ensured, uh, the children were isolated in at homes, so they did not come in contact with other children. So that is one theory that has been given, that that is the reason why KD incidence decreased. But again, no one really knows the answer. But people who believe that KD is an infectious disease take this as proof that because of the isolation, forced isolation, uh, the the infection, whatever it was that causes KD, did not get transmitted.
Thank you, sir. Is there any graded module of cardiological rehabilitation exercise therapy or other, if any, for KD patients on aspirin and atorvastatin therapy? Any graded module of cardiological rehabilitation in KD?
Yes, there are several guidelines available, and the American Heart Association has these published on how to follow up children with KD. So, children who develop coronary involvement, children who have myocarditis, there are modules available on how frequently to monitor these patients, how to follow up these patients. These are available. These are all published.
The next question, possibly you have answered. What is the cause of Kawasaki disease?
Still, no one knows. No one knows. Uh, it probably has an infectious trigger. There is some genetic basis of KD, and that is the reason why KD is so common in children from the Oriental countries. So not only is the incidence of KD highest in Japan, but children of Japanese origin settled in Hawaii. There are several Japanese in Hawaii. They also have incidence rates as high as those of children born in Japan. So that is one genetic basis of KD. But over this genetic basis, there is probably some infectious trigger. But which is this trigger? No one knows.
Okay, sir. What is the novel biomarker and its importance in early diagnosis?
KD even today remains an clinical diagnosis, completely a clinical diagnosis. But in difficult cases, NT-proBNP, we have found it useful. But that is more to corroborate the diagnosis. And you can't, of course, pick up KD just on NT-proBNP.
Then when to give preference of infliximab over IVIG while managing CAD in KD? That a Kaustubh Chaudhary.
So if a child
When to give preference?
if an infant with KD, especially young infant, say less than 6 months, and you diagnose KD in such a patient, we would start with infliximab, then give IVIG, then give steroids and cyclosporin. So this is one situation where we prefer giving infliximab first and IVIG later. The second situation where we give infliximab preemptively is when a child with KD has uh, uh, coronary artery involvement at presentation. So in such a situation, we would give IVIG and infliximab one after the other. So incidentally, Dr. Costa himself has worked on Kawasaki disease for his MD thesis. I can't see him here, but his MD
So that's
thesis
why
was
I
on
mentioned the
Kawasaki disease.
name.
Yeah, yeah.
So how to differentiate MISC and Kawasaki disease?
Well, fortunately, we don't need to differentiate this because we don't see MISC any longer. But MISC had, the rash was a little different. And the coronary involvement in MISC was much milder. It had more of myocarditis. And even when coronary dilatation took place, it was usually transient. And other features like GA involvement was more common in MISC. But fortunately, that is a thing of the past now, and we don't have to do this differentiation.
There is one interesting question. What are the diet relationships with Kawasaki disease?
None to my knowledge, but maybe Priyankar can.
So I think patients who already has Kawasaki disease with aneurysms, definitely they should follow a healthy lifestyle. So obesity definitely is a no. But as a predisposing factor for Kawasaki disease, I don't think we have any idea regarding that.
And is coronary involvement a must to confirm the diagnosis of Kawasaki?
Not at all.
Sir.
Not at all. Because our attempt should be that there should be no coronary involvement. We have to diagnose and treat KD before there is coronary involvement. And this we can do if you pick up KD in the first 5 days. And the gratifying thing is that in many cities in India now, pediatricians are picking up very early KD, very early KD. So if you pick up and treat KD in the say first 5 days, there will be no coronary involvement. This is what we want.
How early an echo can detect aneurysm in Kawasaki disease?
The earliest that you can detect any change in the coronaries is 7 days. So the first changes will appear around 7 days of fever. So
Sir, you have not mentioned aspirin in the treatment.
Yes, I have not highlighted the role of aspirin because it really does nothing as far as the anti-inflammatory action is concerned. And there are several centers now that start from the antiplatelet dose right from the beginning. So aspirin is really not that important, but as a routine, we would give it maybe at 30 mg per kg per day for the first 2-3 days when the fever is there, and then shift over to the antiplatelet dose.
Which is 3 or 5? You would go to 3 or 5?
3 to 5, any dose.
3 to 5, and you would give it for 3 or 6 months?
No, we give it generally for 6 weeks.
6 weeks, not months?
No, 6 weeks. And
unless there was a doubtful abnormal Z score, even if it is borderline, then probably you would err on the side of giving it longer?
If the coronaries at 6 weeks are normal, then we will stop at 6 weeks. But if the coronary changes persist, then of course it will continue for much longer.
And the schedule for echo is 1, and if it is normal, then 2, then you would do it at 6?
During admission, we would do it almost on a daily basis, the first few days. Then at the time of discharge, we would do it. The first on follow-up after 1 week and then after 6 weeks. If the 6 weeks echo is normal, then we would not repeat it.
The next question, sir, when should we go for CT angio of a giant aneurysm, and what are the timings?
If you look at the 2024 guidelines on Kawasaki disease given by the American Heart Association, November 2024, these were published. They have mentioned the role of CT angio in all children with KD who have any coronary involvement. So if you pick up a giant aneurysm, we would do it immediately, even during the acute stage. So if suppose a child comes to us who is febrile and who has large aneurysms, we would do the CT angio immediately. So you can do it during the acute stage, you can do it on follow-up, and repeat it as often as considered necessary. Because as I said earlier, with this radiation exposure, we are a little more confident in doing it more frequently.
And also, if you detected, when would you go in for an interventional coiling?
Interventions in KD can be very tricky. So because the reason is that these coronaries are not normal. So unless there is ischemia, we generally would not recommend any interventional procedure.
No, I mean if you detect an aneurysm.
Yeah, we would just use depending on the size of the aneurysms. If there is small sized aneurysms, we will continue just aspirin. If the aneurysms are large, we would give aspirin and anticoagulation. Continue these children on anticoagulation, follow them up. Interventions in KD are considered necessary only if there is stenosis and the child becomes symptomatic. And these interventions have to be done by a cardiologist and a cardiothoracic surgeon who has special experience of handling these coronaries. Otherwise, you can land up with catastrophes.
What about experience at your center with intervention in cardiac interventions?
Not much.
Because I've read about in US.
Not much.
Sir, next please tell about relapse of KD. Can relapse occur 7 days after IVIG?
Relapses are very, very unusual. So over the last 30 years, we have seen relapses in only a handful of patients. And relapses generally are milder than the original episode. They usually occur in the first few months after KD. And if a child has escaped coronary involvement in the first episode, he will generally escape coronary involvement even in the relapse. So these are extremely unusual.
And would you repeat the IVIG?
Depending on how severe the relapse is. So if the child is having fever for more than a few days, yes, we would repeat the IVIG.
Wouldn't you agree it would be more better to go in for infliximab?
It depends on the age of the child. It depends on the situation. So sometimes you prefer giving infliximab. At other times, you would just give a repeat dose of IVIG.
I think for India, from my point of view, I mean, food for thought. In India, infliximab is going to be cheaper for the older adolescents than IVIG. So maybe you could be doing a randomized control trial where you could see, because now infliximab is cheaper. Maybe Calcutta group can conduct.
You want to say that infliximab as initiation without
No,
IVIG?
I mean, he said while he was suggesting that when do you want to use infliximab over IVIG? So he suggested that in small babies where he feels that there are higher risk, he suggested that he would go for an infliximab in the beginning. And so that's why I'm just saying that, see, whatever we do, there has to be a paradigm shift in life. paradigm shift is we keep doing and then suddenly realize we've been doing it, maybe there's something else. So we never had infliximab because we were taught about Kawasaki ages back. And now, since he said it, I was just thinking in my brain because there was this child who was very upset about starting the infliximab, IVIG, because what happens is IVIG over the count, the what hospital sells you is an MRP, which is very expensive. You know, they may sell to you at 30-40% separately, but medical legally, you can't ask a patient to buy a medicine and in an ICU or some setting and give it because you're responsible medical legally for that. So you take it from the hospital, and depending on the age of the baby, of the child, you are nowadays getting adolescent who are so obese. So that cost is coming humongous. And you're also telling the parent, we think it is Kawasaki. Because as he rightly said, you're not going to wait for a week for the cardiac thing to come. You have to detect it earlier. And those, the pro BNPs and everything we are chasing. And at that time, I mean, we do convince them or make them write IBIG or not. But I'm just giving a food for thought. It's just a loud thought. It just happened thanks to his talking that I just thought, why can't you do a trial and see where people who can't this, because this would be probably cheaper. I mean,
So, Priyanka,
I
lot
think
of questions are pouring in, so I had to
sir,
put in
sir,
the
the
chat
article
box
that
now.
Sir
Surjit's
We will
comments on
have to
that,
stop.
that
Just we will
on the
answer
study.
just
of
few
giving the
questions.
blog.
So, what about the incidence of KD beyond 5 years, especially in adolescents in our country, sir?
Between 5 and 10, yes, we see it quite commonly. Above the age of 10, it's not that common. But between 5 and 10, we see a fair proportion of patients with KD.
That we see lot of patients coming with hand and feet desquamation 2 to 3 weeks after a vague history of fever, which has settled in the by the time the child presents. Should we investigate this patient for Kawasaki?
Yeah, this is a very, very common problem in our country because milder forms of KD, the fever settles down. And if you have the typical periangual desquamation, that is quite suggestive of KD in the last few weeks. So in these patients, you have to treat on a case-to-case basis. We would do an echo. If the child is afebrile and if the acute phase parameters have come down, we generally would not treat preemptively. We would just counsel the parents. But if the child continues to be febrile or if the acute phase parameters are high, then after counseling the parents, we would generally treat these babies. But this is a situation that is seen not infrequently.
So correct me if wrong, the periangual desquamation is also seen in streptococcus?
No, periangual desquamation is virtually pathognomonic of KD, the typical periangual desquamation.
So how often thrombocytopenia is related to Kawasaki disease?
As Dr. Priyankar said, children who have thrombocytopenia and KD usually have more severe forms of KD. And this thrombocytopenia may be a marker of oncoming macrophage activation syndrome. So when Dr. Kawasaki first described thrombocytopenia and KD, in his paper in 1995, in his review article, he had mentioned thrombocytopenia. But at that time, we were not aware of this syndrome of macrophage activation syndrome. So when thrombocytopenia occurs, it is usually a pointer to macrophage activation syndrome. So you have to be very quick in picking up this condition and in treating.
Why perianal desquamation is happening in KD?
No one knows. Why?
Sir, is it possible? Yes, sir. Please, sir.
Desquamation is probably because of the cytokine storm that occurs in these patients. So that it is a form of necrosis of the skin, and it is probably a measure of the cytokine storm. it is possible that children who have more severe desquamation probably have had more severe KD. But why it occurs in KD and not in other conditions, no one knows.
Sir, is it possible to diagnose KD before 5 days of fever?
Definitely. Definitely. The 2024 guidelines, in fact, the deadline of 5 days has been brought down to 4. So it is now fever for 4 days or more. And the reason they have brought down the deadline is because they want to pick up KD early so that coronary damage does not occur. If you have picked up 30-40 patients of KD, you will be confident in picking up KD even on day 3 of fever, because the changes are so typical. The overall facies of the child is so typical that you can virtually smell KD.
So is there a cut-off timeline of giving IVIG? And what is your opinion regarding concurrent infection in KD?
So
Two questions.
IVIG, earlier the better. So we try and give it in the first 5 to 7 days. But there will be children who have had prolonged fever and who present to you after 10 days. As I said earlier, if the child is febrile, we would give IVIG even if the child presents on day 15 or 16. There is no harm in giving IVIG. Concurrent infections are not uncommon in children, and we have recently analyzed our data on concurrent infections, and they were seen in almost 10% of children with KD at Chandigarh. So concurrent infections are more likely to be common from developing countries as compared to the Western countries.
Thank you, sir. Lot of questions are still coming, but it will go on and on because they got you. But we have to stop somewhere. Professor Subrata Chakraborty was pioneer in Kolkata doing this work on Kawasaki disease. So I'll request Subrata give the closing comment and vote of thanks. So over to Professor Subrata Chakraborty.
Thanks, Dr. Sopon Roy, President WPAP, for giving me an opportunity to express vote of thanks on Professor Surjit Singh's speech. It's a great privilege to me. Sir, my regards to you. And sir, your words on Kawasaki disease has inspired everyone in the country who is interested in Kawasaki disease, including me. Professor Priyamkar rightly said that you are the father of Kawasaki disease in our country. Sir, even your small words on Kawasaki disease reverberates into our mind, and that becomes important. Just to quote one, you came to Howrah in the annual conference of Howrah Academy of Pediatrics, and you were speaking on Kawasaki disease. You said that it should be treated by pediatricians. I think so it's very, very important because recently I am in a loop with the patient.
Subrata, just a minute, Subrata, your video is moving. Can you just stop rocking? Please stop rocking.
Okay.
Please stop rocking.
Okay. So this is quoting your right, fine. Just I was quoting one of your speeches in Howrah. You said that it should be treated with pediatricians. It's a very interesting case which I am in contact with. The patient was diagnosed, a small baby, I think 1 to 1.5 years. It's 2 years back. Was diagnosed with Kawasaki disease by a pediatrician. Then, but he was hesitant. He didn't give IVIG. Then, cardiologist was called, and the patient was not given IVIG. And then the parents went for a legal shoot, and still it is continuing. So I think that's a very important that we should be in control. Pediatricians should be in control of treating Kawasaki disease. So, sir, as I said, sir, it is a great privilege to introduce us to express vote of thanks, and I also express my regards to our President, Dr. Neelam Mohan, our National Treasurer, Dr. Atulu Bhadro, Dr. Priyankar Pal, Dr. Vihit Shorkar, who is the Secretary of WBFE. And with these words, sir, again, my regards to you. Thank you. Thank you very much.
Thank you, sir.
Thank you very much. Thank you for
Thank you, sir.
inviting me over
Thank you.
to this
Thank you. We
academic
are really
event.
honored
Thank you,
to
Dr.
have you, sir.
Surjit. Thank you. Thank you.
Thank
Just
you,
a
Nilamji,
revision
for
of things. Thank you.
interacting with Professor Surjit Singh.
He
And we all thought
he pardons me because he knows I am a little academic, so he'll pardon me.
Pedicon 2026 in Calcutta should have multiple KD sessions.
Yeah, definitely.
I think
Yes.
that should make sir very happy.
Okay. Sir, it's
Sir,
an
मुस्कुरा लो,
invitation.
मुस्कुराना सेहत के लिए अच्छा है.
Please give invitation to
सुरजीत जी, आप
Professor
मुस्कुराते
Surjit
नहीं
Singh
हो.
sir to have a special session on Kawasaki disease in Pedicon 2026 in Kolkata. So
Dr.
Atanu,
Dr. Nilamji has noted it. So we'll
okay, sir. Sir, good night,
thank
sir.
you. Good night, sir.
Okay. Thank
We
you.
all have
Thank
to
you.
make him smile, talk, and dance. That's a challenge to all of you. You should laugh, smile, sing, and dance. There, I could give him a smile at last. God bless you, Dr. Surjit.
Thank you. Thank you very much.
God
Good
bless
night.
you. Thank you.
Thank you. Thank you. Thank you.
Good night. Good night.
Thank you.
Good night. Good night.